Sarah, thank you very much for the nice introduction, and dear colleagues. Yeah, I'm honored to present an update about urachal cancer, which is also my special field of interest besides molecular pathology. So these are my conflict of interests very briefly. So the outline for today, I will just briefly talk about the WHO 5th edition important aspects, then about the urachus, a little bit about villous adenoma, and then touch upon the spectrum of cystic urachal tumors, and then come to the main part of non-cystic urachal adenocarcinoma and the results of the 2023 Dublin ISUP Consensus Conference. So as I chose a comprehensive update as the title, I highlighted everything which is kind of new in red, so you can see what is new data out there, and I also added some the years where the research came from. So I will start with the WHO 5th edition changes. You all know the histopathology luckily remains the gold standard for classification. We have site-independent chapters on hereditary, mesenchymal, hematological, and neuroendocrine tumors, and the term variant now is reserved for just molecular alterations. Histology variants now are called subtypes. So there are some specific changes, especially important in this setting. Now, primary adenocarcinoma in the GU tract, if there is a little bit, just a little bit of urothelial carcinoma in situ, we still talk about urothelial carcinoma with glandular subtype. So it's not that you're allowed to call this a primary adenocarcinoma if there is still a little bit of urothelial carcinoma, and even if it's just CIS. The situation is different in primary squamous cell carcinoma in the GU tract, where a little bit of urothelial carcinoma is allowed. Then you can call it squamous cell carcinoma. This is just a very brief update on what might be important also for urachal cancer. So coming to the urachus itself. So the urachus is a structure that develops or connects the forming bladder and allantois. Usually that obliterates already by the 3rd month of intrauterine development to form the median umbilical ligament, which spans from the dome of the bladder to the umbilicus. It's primary extraperitoneal, and there are different types, which is clinically relevant of these remnants. Usually they are 2 to 15 centimeters in length, and the anatomy is that it spans between the transversalis fascia and is posteriorly to the peritoneum. And at the dome of the bladder, it creates the so-called space of Retzius. So patent or macroscopic urachal residues are not that uncommon, and some sources or some papers in the literature say it's roughly around 1% in the pediatric population. Mostly they are under 1 year old, and but in nearly one third or 2/3 of cases they are asymptomatic. And what you can see here, if there are different forms also of macroscopic urachal residues, so there can be a sinus or a cyst or fistulas. If these cysts or whatever get infected, usually this is caused by Staphylococcus aureus or E. coli, and then of course an abscess formation can happen, and this also can burst and cause sepsis, so this has to be taken seriously. When a macroscopic residue or microscopic remain, there is a certain anatomy of this residue. It reminds a little bit of the ureter. You have a muscular layer here, then a little bit of loose tissue, then fibrous tissue, and then the epithelium, which is there around of 2/3 of cases, and in around 2/3 of these cases, it's urothelium, which is quite an enigma because urachal cancer, as you know, usually is an adenocarcinoma, and I will touch upon this later. So there is one study actually which analyzed how many microscopic residues of urachal remnants are there. It's said that it's 32% of the general adult population, post-mortem study. and usually they are located in the bladder dome, very rarely in the anterior or posterior wall. And this is important also for later classification. Urachal remnants can only be seen in 15 to 62.5% of verified urachal adenocarcinomas. This is important for later classification. So this is an image of one urachal case from our institution. So this was a bladder resected for urothelial carcinoma, and this is one thing I want to point out because it's important for urothelial carcinoma, not urachal cancer. It's a well-known fact that in this case, for example, I will try to. Yes, there's the laser pointer. So there is a urothelial carcinoma in situ here, and it grows into the urachal remnant here. You see there is the CIS also colonizing the structure, and at the base of the structure you still have the regular urothelium, what you can see in the urachus. So if this grows deeper and then might infiltrate here, colonization of a urachal remnant by urothelial carcinoma might be a reason for overdiagnosing this cancer. So this is just one thing to keep in mind. I pointed out one paper, but there are several others as well, which identified this problem in staging, which can happen if there is a urachal remnant. So coming to villus adenoma, these are very rare tumors, mostly located at the bladder dome. There's a wide age range. Usually those patients suffer from hematuria or irritative bladder symptoms. Mucosuria, is rarer. And when it comes to histology and IHC, it's completely like the counterpart in the colorectum. It has these slender papillae and pseudostratified nuclei. It can have low grade, but also high grade and an adenocarcinoma in situ. And then it's important to look for adenocarcinoma, invasive adenocarcinoma. So sampling is an issue here. There's an excellent prognosis. And in the next image, I have a higher magnification of one case. This is something you would or one wouldn't be able to distinguish from a case from the colorectum. So we have these papillae villus structure. You have the pseudo-stratified nuclei, which can be low grade or high grade. So coming to the spectrum of cystic urachal tumors. So the seminal paper in this area was published by Amin and colleagues roughly 11 years ago from 55 cases. And it has already been embedded in the WHO classification in 2016, so the 4th edition, and also in the current WHO classification 2022. And the tumors that belong to the spectrum are the mucinous cyst adenoma, the mucinous cystic tumor of low malignant potential, and the mucinous cyst adenocarcinoma. The first one is the mucinous cyst adenoma, which is also rare. Usually is also located in the midline as a cystic mass. There's a wide age range, and the signs are unspecific. And if you look to histology, it's lined by a single layer, sometimes a little bit tufted, of a mucinous epithelium without any atypia. So it's very similar to what you can see in the ovary, these mucinous cystic tumors in the ovary. The important thing in these tumors also is sufficient sampling to exclude dysplasia or even a carcinoma. And actually, that's very similar to what we see in the ovary. You also have to sample these tumors very well. If it's excised completely and it's just this mucinous cyst adenoma, of course, the prognosis is excellent. A little bit different is the mucinous cystic tumor of low malignant potential. Is also very rare, is a midline cystic mass as well, similar age range. The signs are also unspecific. And the difference here is that the mucinous epithelium, I will show on the next slide, I will show a little bit of histology. The mucinous epithelium here can be flat, or a papillary, can have some tufting, and has mild to moderate cytolytic atypia, so low grade, no high grade. And it, of course, doesn't show any invasion. It's also similar to an ovary tumor, and this is the mucinous cystic tumor of the ovary with borderline malignancy. And as we also do this in the ovary tumors, sufficient sampling is very important. Also, this tumor has a good prognosis. And looking to histology, this is one case which displays these large mucinous epitheliae here with the nuclei which are orientated at the basement membrane, so everything fine, no dysplasia, and then this area here of low-grade dysplasia and also associated with the urachal remnant over here. Coming to the malignant part in this spectrum is the mucinous cyst adenocarcinoma, which, as the name suggests, is of course malignant. It's also a cystic mass. It has high-grade mucinous, high-grade dysplastic mucinous epithelium, which can be glandular, papillary, cribriform, and it has a frank invasion. And this is the only tumor from the spectrum where there's a little bit of debate, because in the primary publication from Amina and colleagues, they set a threshold for microinvasion of 5% of the tumor, less than 5% of the tumor volume, or 2 millimeters. And as I will show later, of course, there is not a lot of data to support this afterwards, and therefore during the Dublin consensus, we couldn't decide how to deal with this threshold. I think we just need more cases to see how it works. So it has an adverse prognosis, but it's not as bad as the non-cystic urachal adenocarcinomas show, and everything else is completely similar to the cases of non-cystic adenocarcinoma epidemiology, clinical feature therapy, IHC, and I will show this then in a minute. So these are images. As you see, it's a cystic tumor. It is more multiloculated. It has these mucinous extracellular masses, and this is also kind of specific, these calcifications, but they can also be found in the non-cystic variant of mucinous non-cystic urachal adenocarcinoma. And in some of the radiological papers, it's said to be pathogenomic, but actually, as we see it also in other mucinous tumors, maybe of the colorectum, also these calcifications can develop. So one has to keep in mind, of course, the localization in the midline and also the other histological or radiological features, and of course, histology. What you can see here is the lining of this carcinoma, and then this frank invasion of a tumor that shows here morphology, which is kind of similar to colorectal adenocarcinoma. So coming now to the main point, the non-cystic urachal adenocarcinoma. Why it's the main part of this talk? The reason is that it's of this very rare tumor type. It's the more common one. And actually, we in our group, we performed a meta-analysis of epidemiological studies from the US, Canada, and Europe, and also Japan. And the overall incidence is just 0.2 to 0.4 per million people years. And that's the standard, as you can see here in the Western countries. It's said to be a little bit higher in Japan. And of course, in such a rare tumor type, it's very difficult to say what the reason is, because there might be diagnostic reasons, epidemiological reasons, just some other biases, or even environmental reasons we don't know for sure. So men are usually affected more. This is consistent in all the literature. Roughly around 2/3, 60% are men. The median age is, 52 years. And of course, it derives from the urachal remnants. Some sources talk about a bimodal age distribution in these tumors. That's actually not the case. So you can see that the incidence is growing over years, but also young adults can get, especially female patients, can get these tumors. We don't know why yet, but I think we have to do some more research. But the mortality is kind of high in younger patients, and it drops to a lower rate at the age of around 60. The localization of non-cystic urachal adenocarcinoma is usually in the bladder dome, very rarely along the median umbilical ligament or anterior posterior wall of the bladder. Median tumor size is 3 to 6.3 cm. We don't know the pathogenesis. I already talked about this a little bit. The common notion is that usually there is a little bit of chronic inflammation, which causes metaplasia to this glandular epithelium, then dysplasia, and then carcinoma. We are currently doing a study to see if this is true. If there is some spectrum, we haven't analyzed the data yet, but hopefully we can get some information out of this. Another theory is that there is some displaced cloacal epithelium. There is no familial clustering and no known risk factors. There's one study now from 2 years ago that suggests, I will show this later, that there might be some dietary or some smoking habits that might predispose to urachal cancer as well. I will show this later. So the overall majority are adenocarcinomas, but the urachal remnants, as I said, are usually lined by urothelium. The clinical features, they are non-specific in early stages, and usually the patients present with hematuria. And this is a problem, of course, not just in bladder cancer, but also in urachal cancer, because until urachal cancer can develop hematuria, it has to invade the bladder cavity. And then usually these cases are kind of big and already progressed. And this is also the reason why urachal cancers usually do not have a good prognosis. It's better compared when stage matched to urothelial carcinoma of the bladder, but still is not very favorable. Sometimes patients also show up with abdominal pain, dysuria, mucosuria, and a palpable tumor, the non-specific UTIs. As I already said, CT shows calcifications, cystoscopy usually is positive, and tumor markers in the serum like CEA, CA99, or CA125 can be very useful, but usually in monitoring the disease, not in primary diagnosis. Prognosis is adverse, so the median prognosis of all stages is around 50%. It's better compared to matched urothelium and also adenocarcinoma of the bladder. And in multivariable analysis throughout the literature, higher stage, Sheldon stage more than 3B or Mayo stage 2 is prognostic. Also, if present lymph node metastases and positive surgical margins. I highlighted this or just shaded this one, ECOG status, because that's not congruent through the literature. This is just here from also a well-known paper in the field from Bruins and colleagues from the Netherlands in 2012, showing Sheldon stage and surgical margins, but not lymph node dissection per se, to be prognostic only if there is a metastasis. And this is also a very well-known paper from Wright and colleagues analyzing the SEER cohort in the US from 2006, showing that a non-urachal cancer has a worse prognosis. Okay, so coming to staging, there are different staging systems, and the famously the Sheldon staging system was presented or published in 1984, and per se it's that's a system which is prognostic, but the most cases cluster in this region and are detected in a higher stage than 3B. The Mayo system, published in 2006 by Ashley and colleagues, usually the patients are in stages at least Mayo stage 2. And I will talk about this when I touch upon the results of the Dublin consensus. There is one new proposed modified TNM AJCC system from Limonik and colleagues from 3 years ago. They used the TNM system, which of the bladder cancer, which of course is not primarily designed for urachal cancer, because urachal cancer usually develops within the bladder wall, and Usually they cannot be a T1 case, or very rarely in urachal cancer, because usually these residues are situated deeper in the wall. So they orientated and modified the system in this way. This would be T1 here, invasion of the bladder muscularis propria or perivesical tissue. Is PT2A and B and 3A. The macroscopic invasion and also invasion of nearby structures would be T3B and 4A, and this stage invasion of pelvic abdominal wall, peritoneum, or any nodal or distant involvement, this would be T4 and then N1. Also, the diagnostic systems have developed over the years. So the first systems have been published by Mustafi and Wheeler and Hill in the mid-50s, 54 and 55, and have been adopted and a little bit modified by Sheldon in the famous 1984 paper. And in the course, as we learned more about urachal cancer, these systems were found to be too strict, especially because of the mandatory presence of an urachal remnant. What I already said, maximum would be roughly 2/3 of cases where you can find urachal remnants in clinically validated cases, and also the exclusion of a cystitis glandularis or cystitis cystica. Then Harry Herr from Sloan Kettering, 2007, shows a very strict approach and said everything which is at the top of the dome of the bladder clinically is, if there is an adenocarcinoma, it's urachal adenocarcinoma until otherwise known or proven. So Gopalan and colleagues from Sloan Kettering as well, they modified the primary system from Sheldon and had these criteria: location of the tumor at the dome of the bladder or anterior wall, epicenter of the carcinoma in the bladder wall, absence of widespread cystitis cystica or glandularis, and absence of a known primary elsewhere. So this system and also the other systems has been modified by the current WHO classification as well. I will not read everything because we all have the blue books and we can look it up. But these thoughts have been implemented in the current WHO 5th edition classification as well. So as we know, that cystitis cystica is not really, or glandularis is not really predisposing. And this is a discussion in primary bladder adenocarcinoma, but especially not for a urachal cancer. And the mandatory urachal remnant has also been dropped. Coming to the histology of non-cystic urachal adenocarcinoma. So this is the enteric type. We have also mucinous type, signet ring cell type. And this is very important to say, because the enteric, mucinous, and signet ring cell type, they can look very much alike other tumors from the GI tract or also metastasis from elsewhere. So histology alone is not sufficient to diagnose this cancer. We also need the clinical information and maybe imaging as well, maybe some molecular results. I will talk about this a little bit later. So the enteric type is the second most common histological subtype in urachal adenocarcinoma. It's exactly like what you see in colorectal cancer. It has this gland formation, this dirty necrosis, cribriform structures, pseudostratified cells, which are high grade and lose the orientation to the basement membrane. The most common subtype is the mucinous subtype, where you can see the extracellular mucin, which can also be blue, and the tumor cells in clusters just floating within the tumor of high-grade morphology. And you can see some signet ring cells in here, but it has to be by definition, lower than 50%. In the signet ring cell type, we see standard signet ring cell histomorphology, also with extracellular mucin. And in these cases, it has to be more than 50% signet ring cell part. The NOS, so the not otherwise specified subtype, shows glandular morphology, which isn't recognized as enteric or anything else. And this is especially difficult here to distinguish from maybe urothelial carcinoma with similar morphology. And this is something really to think about and to have a good grossing and also of the bladder mucosa and macroscopy. So can immunohistochemistry help in the diagnosis? So if you look or you have the differential diagnosis from urothelial carcinoma with glandular differentiation, it can help to some extent. I will show this later, but the problem really is colorectal cancer and primary bladder adenocarcinoma to distinguish these two from non-cystic urachal adenocarcinoma because they have kind of the same IHC criteria. They usually are positive for CK7 and also some are positive for CK20. And one thing that can help a little bit is the nuclear reactivity from beta-catenin. So APC mutations are, we know this from colorectal cancer, are way more common in colorectal cancer, and there is a but can be found also in urachal adenocarcinoma. So you cannot be 100% sure that if you see nuclear reactivity in such a case that it's colorectal carcinoma growing into the bladder. There are cases of urachal adenocarcinoma that show APC mutations and then beta-catenin nuclear positivity, but that's way rarer. So differential diagnosis from urothelial carcinoma with the glandular subtype can look exactly like urachal cancer. The glandular component is also CDX2 positive, so that doesn't help. So in UCG, also in urachal adenocarcinoma, but GATA3 can help a little bit. And if you have access to molecular, then TERT promoter mutations are way more common in these UCGs than in urachal cancer. Urachal adenocarcinomas. There are some cases, actually, I have seen one, and we looked into this case very long to exclude that it's anything else, but it was just this one case in a cohort of roughly 40 cases. So it's a rare event. And to distinguish from Mullerian tumors, that's easier because, as we know, morphology is a little bit different. We have this papillary tubulocystic tumors with clear cell morphology, and immunohistochemistry helps here a lot because PEX8 is positive, and PEX8 is not positive or shouldn't be positive in urachal cancer. We don't know a lot about the molecular background of these tumors, and there can also be some associated findings. Even rarer, the endometrioid adenocarcinomas of the bladder, and these can be found, of course, mostly middle-aged or elderly women. They are exceptionally rare, even rarer than urachal adenocarcinoma, and can be found mostly at the posterior wall. So coming to molecular findings. So urachal carcinoma is on the molecular level, it's kind of similar to colorectal carcinoma, more similar than to urothelial carcinoma, or even bladder adenocarcinoma. And that refers to the mutational profile, but also to the methylational profile, microRNAs, and other things. So this is not yet published. This is from a meta-analysis our group just performed. It's submitted, but not yet published. So we looked for the overlapping molecular mutational profile. So you see it's more shared between the primary bladder adenocarcinoma and urachal cancer adenocarcinoma than with urothelial carcinoma's glandular subtype. The most commonly found mutations are in TP53, not surprisingly, because that's the same in other tumors as well. KRAS mutations are common, but unfortunately not the KRAS G12C mutations, which are targetable now by sotorasib or adagrasib. As we know, SMAD4 mutations are commonly found, which are also found in colorectal cancer, and DICER1 mutations, which is interesting. Urachal cancer usually is low in PD-L1 expression, usually is microsatellite proficient, and has usually a low tumor mutational burden. So this is the first update paper I want to show. This is from the group of Yang and colleagues from Shanghai. They analyzed 23 patients, including 7 urachal adenocarcinomas. They performed whole exome sequencing and whole genome sequencing, and also bulk RNA-seq, single-cell RNA-seq, and survival analysis. And actually, they found the mutations we know about, the KRAS and TP53 mutations. Here's just illustrated the mutational profile. But what importantly, they found that there are signatures in these tumors as well. So when it comes to the RNA sequencing data, the bladder adenocarcinomas and also the urachal adenocarcinomas, they show more luminal subtype compared to urothelial bladder cancer. And importantly, they found a signature that indicates the chemical carcinogenesis. And there are signatures of smoking, some drugs, but also of aristolochial acid, and some cases displayed high immune infiltration, and these cases usually had a better prognosis. Then other cases displayed ApoBec signature with low immune infiltration, poor prognosis. So we will see in which direction this will develop, but this is the first paper that shows some signatures and might point out to some carcinogenesis model, which is modified by external carcinogens, because usually urachal remnants, they do not have any access to the bladder lumen, so they should not have the same carcinogens, because there is no local effect through the urine on the mucosa. So this is still an enigma, but this is the first data we have. Coming to localized therapy. So that it's the standard since some years now to perform partial cystectomy in urachal adenocarcinoma, because some studies have shown it has the same or similar oncological results compared to complete or radical cystectomy. And of course, the quality of life is way better when just a part of the urinary bladder is removed. So there is a lot of literature, especially also from MD Anderson Cancer Center some years ago. But the clinicians, they didn't have any consented recommendations to use a partial cystectomy, and this is now piling up. There is one paper published in European Urology this year from the International Bladder Cancer Group, and it specifically states PC should be offered to patients with urachal adenocarcinomas that are amenable for resection with adequate margins. Adequate margins, that's of course important, because positive surgical margins is one of the most important prognostic factors. And also, if you have the signet ring cell type, we all know this can be very diffuse and not really good seen in prior radiological examinations. So usually also the median umbilical ligament is removed and the umbilicus. The role of lymph node dissection is under debate. General lymph node dissection, meaning that in every case, specific parts or specific regions of the lymph nodes are dissected. If there is any indication in the preoperative imaging results that there is lymph node metastatic disease, then these should be resected, because that's also a very strong prognostic factor if there is metastasis, but it's not clear if it should be done in every case. There is also a debate about the role of laparoscopic surgery. This paper from Drobot and colleagues just very recently, and they highlighted the role of robotic surgery in urachal cancer, but there are also some concerns from other groups For example, this Dutch group here, which say there is a risk, and they also saw it of seeding. So this is also still a little bit under debate. Coming to chemotherapy in advanced disease, also there are no standardized guidelines. Radiotherapy is said to be less helpful in urachal cancer. And over the last years, chemotherapy regimes in urachal cancer have changed because orienting at the histology, which I already lined out, is closer to colorectal cancer, has moved away from regimes used in urothelial carcinoma now to ones used in colorectal cancer. So there is some consented statements, especially here from Canada, and also the French GU tumor group. They use this, and also from Sloan Kettering. We performed a meta-analysis some years ago, also showing that 5-FU plus platinum in those cases, the meta-analysis from was most helpful. And now there's the first prospective data. So this is the Ultima trial. It's a multi-center, 5 centers, 21 patients, of course, for urachal cancer, quite a lot, in Korea. It's a single-arm study, of course, open label, and they used a modified FOLFIRINOX system and pegtorogras for 2 weeks or for up to 12 cycles. So the overall response rate was 62%, which is good, and also the rest had stable disease. So this is finally some prospective data we see. The median overall survival was roughly 20 months. PFS was 9 months, and no unexpected adverse events were noted. The caveat here is that the final survival data has to be awaited. Also, the molecular data has not been published. Of course, it's a small cohort. That's always the case in urachal cancer. Patients had a good ECOG status from 0 to 1, and the median age was very young. So these are doing, not elderly patients. So we have to be careful to transfer these data to elderly patients. But it's the first prospective data, and this is, I think, a very important thing. Coming to also targeted therapy, we have now a lot of agnostic approvals. This is just an example what's there in the US and also in Europe. We have the FDA approval of pembrolizumab for MSI-H or high tumors and TMB high tumors. We have larotrectinib and entrectinib in both world regions for NTRK-fused solid tumors. We have selpercatinib, which is approved for RET fusion-positive cancers, and also dabrafenib with BRAF V600E mutations combined with trametinib for MEK inhibition, and trastuzumab deruxtecan as an antibody-drug conjugate approved by the FDA for unresectable or metastatic HER2-positive solid tumors. We do not have that in Europe yet because there are still some study data lacking. So what's the situation in urachal cancer? So this is just an example. It's a study, one of our studies, but of course there are other studies. We performed NGS, mid-sized panel, just 161 genes, 41 urachal cancer cases. We found 191 pathogenic mutations. Of course, KRAS mutations were very commonly found. And the important thing was, so we combined this with a key again system to see if there is any targetability in those alterations. And we saw in 94% of cases, so 31 of 33, we saw something that might be targetable, just to be very, very, to be aware of what's going on here, because we know it's just based on a biological rationale, and when we, from our own molecular tumor board results, we see these usually do not get recommended, and also only very few cases really go to targeted therapy. But nevertheless, urachal cancer cases, they do have some kind of targetable alterations, and this is one thing to keep in mind, not for diagnosis maybe of urachal cancer, but for therapy in advanced cancers if there is nothing else to do. So we also have the first prospective immunotherapy data in urachal adenocarcinomas. This is one study that included rare genitourinary tumors, and also urachal cancer cases were included, adenocarcinomas also from the bladder. And 15 cases were included, and this, unfortunately, you cannot separate the adenocarcinomas of the bladder from urachal cancer cases. The overall or disease control rate was 80%, and the urachal cancer cases were in the cabozantinib and nivolumab cohort. So this is also very recent data, first prospective ICI data in urachal cancer. Also, antibody drug conjugates are a thing now in urachal cancer. We all know this concept from trastuzumab deruxtecan or others, and also in bladder cancer from enfortumab vedotin or sacituzumab govitecan. I will not go into detail here. So what's the expression of these targets in urachal cancer? This is a study from China, from Han and colleagues. They analyzed 41 urachal cancer cases in a TMA-based approach, HER2, Nectin-4, Claudin 18.2, TROP2, mesothelin, and PD-L1. What they saw is TROP2 is high, and the other things are low. And this is also what we saw in other studies, also in our cohort, but they also saw here it's the TROP2 expression. If it's high, it's a multivariable factor for adverse survival. So there is some kind of ADC-related protein expression in urachal cancer, and there are already three trials, to be honest. One is from Emory. I haven't outlined it here in detail. The first one is the SMART trial, NCI-based trial, phase 2 basket trial, which is active and recruiting already since August last year. Goal is 60 patients, and they want to combine sacituzumab govitecan, which is TROP2 ADC mono in patients which have been immunotherapy treated before, and in ICI naive patients, sacituzumab govitecan with atezolizumab. Urachal cancer patients can be included in both arms. Primary endpoint is overall response rate. They also include some kind of translational research, and we are very much looking forward to the results of this trial. And also from the same group, this is another one, the Urachal trial with enfortumab vedotin in ICI-treated patients as a monotherapy, and in ICI-naive patients combined with pembrolizumab. This is not yet recruiting, also from the NCI, 68 patients, that's the goal. And it's apart from that, it's a very similar trial. We are waiting this data in 2 or 3 years, and we're very much looking forward to this. This is just a table to show which of clinical trials are going on at the moment. This is a table taken from our manuscript, which has just recently been accepted, so that can be looked up afterwards in the literature. So coming now to the Dublin ISUP Consensus Conference. So we met in 2023, and thank you everybody again who's been there in Dublin. It was really great achievement, and I'm very proud that this worked out. So there was one day before the European Conference on Pathology. We had 80 participants, mostly pathologists, but also clinicians. The pre-meeting survey included 125 participants, mostly pathologists with more than 10 years experience and from academic centers. We could achieve a consensus in 89% of the statements, and 2 papers resulted, which have been published this year. So I just want to highlight the most important results. So one is that nearly everyone would recommend the WHO 2022 criteria to diagnose urachal adenocarcinoma and also the non-glandular types. I didn't outline this because it's not rarer, but there has been this classification from Pena and colleagues in, I think it was 2016, correct me if I'm wrong. And also other important findings are that when we face the diagnosis of urachal cancer, including the cystic types, do we need a specific approach for the resection specimen? The answer was yes. And also for grossing, because there are no guidelines for grossing at the moment. most of the participants said if it's 5 centimeters or less, let's embed it completely. And if it's larger than that, then include 1 section per cm of the tumor. Concerning mucinous cystic tumor of low malignant potential, would you apply a cutoff for the extent of intraepithelial carcinoma? And the consensus here was no. So what the participants said was, if there is any carcinoma in this tumor, it's a mucinous cyst adenocarcinoma. That's what this consensus means. And also there's this uncertainty, what I already said about this threshold here of less than 2 millimeters and less than 5% of the tumor in cystic adenocarcinomas to call it microinvasive. There is just not enough data to support this yet. We will see in the future. Another important consensus was that we should use immunohistochemical markers for the differential diagnosis in TOR specimens just if we need it. So it's optional, and it's important, I think, that it remains this way. So coming to staging, this is also an issue because, as you can see, most of the participants said we would like to use another system than the systems we have at the moment. So the participants also said we should modify the system we have for TNM AJCC for bladder cancer, and this goes back to the Limonic paper I mentioned before. But we will have to prospectively validate using a large cohort. So, excuse me, this is one thing that we would need to think about in the future. In the aftermath of this consensus conference, we talked about setting up an ISUP registry for urachal cancer. I have not included the slides here because it's not really up and running at the moment. We thought we would be faster. But unfortunately, this is not that easy, especially here in Europe with so many countries and different regulatory systems in the different countries. But when this registry will be up and running, I think we will hopefully have another ISUP update on this, or just some note. Because I think it's important. It's important that everyone can take part in this initiative, that we can do research together, and that we have a large cohort so we can address questions like staging, like grading, because there is no grading approach at the moment. Also, maybe identify some therapeutic targets, and it's not a closed job. It's for all of us, of course. We have to have a specific framework, but I think this will be a good thing in the future. So coming to reporting, I do not want to read everything of this, and this is the reason we condensed these points to one table, which can be found in the next chapter of urological surgical pathology on urachal cancer. So what to report in TOR specimen and surgical resection specimens is histological type, grade, LVI, bladder surface, mucosa status, metaplastic changes, and presence of urachal remnants. That's what set is for consideration. And in surgical resection specimens only, the demarcation between the tumor surface, bladder surface, mucosa, peritoneal involvement, invasion to adjacent organs or tissues, surgical margin status, of course, and if there are lymph nodes, then we have to report it. Coming to the summary, because I hurried up at the last slide a little bit, because I hope we have a good discussion afterwards. So general points from the updates is we have the first recommendations for partial cystectomy from professional organizations, International Bladder Cancer Group, also from the Canadian GU group and from the French group. We have the first prospective clinical trial data on chemotherapy, the Ultima trial in urachal cancer. We have the first prospective clinical trial data on immunotherapy in cabozantinib and nivolumab. We have the kind of advanced understanding now in the molecular backgrounds on urachal cancer, and the first clinical trials for ADCs in combination with immunotherapy are up and running. The SMART trial with sacituzumab govitecan plus minus atezolizumab, on the Virtue trial with enfortumab vedotin plus minus pembrolizumab. So this is one thing that developed during the last few years, and the pace is it's stepping up. So it's I think for the patients, that's a good thing that they can now get some be included in basket trials. Regarding the consensus classification, we reached consensus using the WHO 22 criteria to use a specific sampling approach to embed tumors less than 5 cm completely, and 1 block per cm larger than 5 centimeters. We had consensus for no cutoff for extent of adenocarcinoma in situ in MCT LMP tumors. The use of IHC for differential diagnosis is still optional, and modification of the TNM AJCC system for bladder cancer is hopefully taking place in the near future, maybe also using the system already proposed by Limnomic and colleagues. We had no consensus for use of criteria for microinvasion in mucinous cyst adenocarcinoma and the use of current staging systems. So this was the parcours through the urachal cancer updates, and I hope you enjoyed it and we have a good discussion afterwards. This is Frankfurt. I will move to the place I came from, Essen, in 3 weeks' time. So hopefully we can set up everything there as well. I will stay in the GU community. I will stay professor for molecular pathology, and so everything will stay the same, but in another city. So thank you very much for your attention.
Thank you so much, Dr. Reis. We already have a couple of questions in the Q&A, and please continue to put them there. We'll take at least another 10 minutes to go over the questions. So going back to earlier in the lecture when you were talking about glandular lesions and villus adenoma, the question is how you would distinguish a villus adenoma from a metastatic or secondary involvement of colorectal carcinoma.
That's a good question. So if there is no invasion, I think you can be pretty sure that's primary. And I think endoscopy here is the key, because in those cases, and that's also the way I know the clinicians do it, they would do a colonoscopy and maybe also gastroscopy, and then you can be quite sure. Yeah.
Yeah, I think that's the answer a lot with some of these glandular lesions that morphologically and immunophenotypically cannot be distinguished. We've got to use our clinical correlation. The next question is, do you ever suggest urachal origin in a TURB report? What are the clinical and preoperative criteria that would enable surgeons to kind of decide if they're going to consider partial cystectomy versus, an actual bladder adeno?
That's a difficult question, actually, because I would never say it's a urachal carcinoma in TURBT specimen, actually, because you always have to keep the differentials in mind. And this is primary bladder adenocarcinoma. If you are lucky, you have samples from the rest of the bladder. And if you see intestinal metaplasia with strong dysplasia, then it's more, it might be primary bladder adenocarcinoma. But I think also the most important thing is the tumor board, and to discuss it with the radiologist and with the urologist, see the CT scans and see if is there a tumor which is at the bladder dome invading from the outside. Histomorphology would be fitting for urachal adenocarcinoma, and the colonoscopy is negative. I think then you can say it's urachal cancer preoperatively. We cannot be sure, so we also try to do molecular or biological analysis. But actually, everything's fine. It's just research, but we haven't had anything that can be sufficiently distinguish these tumor types. So it's always between those disciplines.
Yeah, and you mentioned calcifications. I also feel like our radiologists lean into that finding quite a bit and love to point it out. But, it's certainly not, entirely specific. But that is definitely an issue. that comes up. I had a question. I can go to the paper, but I believe it was in the paper, maybe the Shanghai group with the urachal and the most recent sort of molecular findings with the basal subtype doing worse. Did they give any indication of any differences in histology for those, any subtypes that were overrepresented, anything like that?
Actually, no, because there are so few cases. I think
Yeah.
we have to be very careful to be too specific about the data. It's great. This is a great study, and yeah, I envy them for this study, but still we need more studies like this to be sure that we can make certain decisions.
All right. We've got a question from Dr. Reuter, where he thanks you for your comprehensive presentation, as do I. The question is, given the modifications in the definition of what qualifies as urachal adenocarcinoma, do you have any concerns regarding the recent molecular findings, therapeutic response, and clinical outcome data?
So can you repeat the questions, please? I
Yeah,
had some glitches here.
so I assume this is referring to changes in the diagnostic criteria for urachal adenocarcinoma, where we've gotten a little more broad in what we'll permit. Do you have any concerns regarding the recent molecular findings, therapeutic response, and clinical outcome data?
Yeah, that's also a difficult question. I think the result of the therapy is that what is important. If we classify a tumor correctly as urachal and partial cystectomy is performed, and we have negative surgical margins, and I think it doesn't really matter if this might be some academic wrong classification. And if you have a case that is advanced and you have certain targets, and you can maybe include, especially in the US where these clinical trials are running, you can include patients in the trials, then it's just great. And if it's a primary bladder adenocarcinoma, or if it's a urachal carcinoma growing into the bladder, if these tumors display certain therapeutic targets, I think that's the point. And I think that's an interpretation from the point of view of the patients more than from the criteria.
Sure, and I think as we begin to explore more tumor agnostic uses for tumors, we will always be needed, and we'll always be providing as much, histologic detail in addition to staging and grading any tumor. But, there are changes in how that histologic diagnosis impacts therapy
Yeah,
now. And
yeah,
so
and
I
we
think
see
that's
this.
just, yeah,
Yeah,
it's just a new world.
yeah,
Yeah.
and especially we see this also in other tumors. So the agnostic thing is great, but if you see, for example, looking at trastuzumab deruxtecan in every tumor type, you see the HER2 3+ positivity is relevant, but it's not relevant, or it's not that relevant, for example, in lung adenocarcinomas where the mutation is important. And so I do not advocate for leaving out the histology. Of course, I'm a pathologist. But I think it's a combination, and we still need the morphological and the organ context to have an informed decision on what to do. We cannot just do molecular, say, that's that target, let's use this drug. That's just not enough.
Yeah, I agree. I think probably all of us on this talk also agree.
Yeah.
All right, so we're at the hour and I don't have any additional questions coming in. So I will take this time to thank you again for a really, again, comprehensive, from everything from diagnostic considerations to this emerging molecular that's, very important in understanding these rare cancers. And also just, again, a plug for trying to identify ways to get larger cohorts so we can study them and have some more meaningful data to come out of them. So thank you very much for your time. Thank you all for joining. We're going to take a break for December, and we'll be back in January for the next ISUP Presents. So thank you all, and have a great rest of your day.
Thank you very much.
Take
Goodbye.
care. Bye.